Okay, we have some time now for questions. Before I open it up for questions to the group, I wanted to say, try to synthesize. I don't know if I can possibly even attempt to synthesize Eva's talk or any of the talks, but I think some key themes come out for us to discuss and to think about how we move, particularly from research into action, into policy and intervention. Again, getting back to what do we do, for whom, how do we know it's working? Clearly, I think all three presentations emphasize for us the role of the urban poor and community members as experts, not just as in consultation in our research, but actually actors, active actors in the data, identifying problems, collecting data, analyzing, and moving into solutions, and importantly, as we've heard, to do the evaluation. If we're going to track success on the SDGs and the new urban agenda, community members need to be seen as researchers and active scientists in that process, particularly, as we've heard, women and youth involved in this work. And this is the idea of this co-production of expertise and knowledge, a combination of different kinds of expert knowledge to understand risks and the effectiveness of interventions, the local knowledge, the biology, the ecology. Understanding communities and cities as really complex systems. They're not monocultures. As we've seen, this integration and intersection, we can't approach urban slums or urban poor communities just with one exposure, one behavior, one risk at a time. They're much more complex than that. People are not one day suffering from diarrhea and then the next subject to violence and the next discriminated in the workplace, et cetera, et cetera. So Eva talked about eco, bio, social, cultural, the intersection, and making that explicit in our work seems to be an important dimension here. I think another theme was the emphasis both on people and place, not either or. So it's not just focusing on the hot people or the hot places, but thinking about both and how those things both co-constitute risk, exposure, and help us identify solutions. The notion of learning by doing. This is also deeply engaged in sort of ecology, sort of an adaptive management approach, that we're not going to build all the models and find the solutions a priori. We need to learn in and with communities, but at the same time build robust monitoring and tracking and data feedback systems, as Eva has just and others identified interventions that build that monitoring and tracking into the actual project, and then adjust and learn as we go. The problems seem too complex and too challenging to think we can do this just from the lab and then implement it in places. And finally, I think the linkage between local, urban, community scale projects and linking that to policy. And keeping those linkages and the evidence base connected seems to be a critical piece of moving to health equity interventions. Okay, so now I'm opening it up to questions, members. Okay, I'll start with David.
Thank you all for really nice, stimulating presentations. I was trying in my own mind to distill what I heard from each of the three, and in a very simplistic way, my own little version of, I think, what Jason said more with greater depth and expertise is basically, how do you make useful and measurable goals locally meaningful or compelling, let's say. So two questions. One's a more specific question for Eva, and the other is just a question for the three of you. So Eva, I just want to make sure I know what it was that the local community members understood to be the measurable goal. It wasn't reduction of salivary dengue antibody prevalence or titers, et cetera. I assume that was not it, because that, to me, would be a much more difficult, in sort of less tangible goal that has less direct meaning or understanding for, understandable meaning for daily life. So what was their
It's just involving them in the whole process, saying dengue is a problem, it's transmitted by mosquitoes, and we need to get rid of it. And this is how the mosquitoes, are essentially, this is the life cycle and this is the problem. Like how do you, but understanding that the virus is transmitted by mosquito. And so we really explained, like, you can be infected but not be sick. When when you have another infection, it can be worse. So showing that your child has been infected by dengue is very powerful. So they were totally involved in understanding, what is a pupa. I mean, amazing. They know what a first instar, second instar, like they really understand like the larval stages, the pupal stages. I mean, how to use ovitraps to figure out like that the dump over there is where the mosquito, are coming from. And so they really became citizen scientists, many of them, through this process. It's being not afraid to, explain the process and then have that, make sense in the way that it can be processed and what are the interventions that can then come out of it. So the concept was to reduce dengue. And so we had testimonials, about my son had dengue emerging fever, it was very frightening, my, brother died of it, et cetera. So the reducing dengue was the point, right? So but then how you get there was understanding that it's transmitted, the virus is transmitted by mosquito, and the life cycle is critical to controlling and eliminating the breeding site so there's no mosquitoes. And then how you do that was what they figured out. But the evidence was the larva, and the pupa in their own homes that they can count, and getting right back to them with that information about whether their children had been infected with dengue. And so they were processing that information, and it was very, very motivating to know that, even if their kid wasn't sick, they understood that they'd been infected and were at risk for more severe disease.
Okay, so that's really interesting because to me, that takes a certain leap of either faith or understanding in what the meaning of those serologic results are and how that translates to what might be a much less common, observable case of disease. But that's great. So then the general question is, how are there general features of these measurable goals that makes them compelling for whatever the local population? Are there certain general rules or particular ways that you would try to define these goals, thinking this is likely to work because it has these various features?
I just want to say, so now that was during the CRCT and that whole 10 years of studies. Where it's going now is not using serology, actually, because that's like you have to collect it and it's being analyzed by the lab and et cetera. So right now it's actually working just on the entomological evidence. But I mean, for me, the critical piece is the evidence. It's the people's own evidence in whatever. I mean, it doesn't have to be, larva, that is in this case, because that's important with Aedes mosquitoes. But, I think that what you're asking, what is it that you work from? You work from evidence that people can measure and they can see how they're doing. But
I'm also asking, what are those whatevers, the things that you just said, measuring whatever? Could it be whatever?
Daniele is going to tell us what that would mean for WASH. Like, what's the critical piece of evidence that's going to show you that you are either controlling your, nos va mal, nos va bien. What is that? And every area is going to have that critical piece that is measurable and that can be acted upon, and it makes sense and is tangible for that community. And it's going to be different in each of our areas.
And I think to address the WASH piece, it doesn't have a great measurable goal. It's like if you treat your water, you're going to reduce half your diarrhea of your under fives, right? So under fives aren't the most kind of economically active part of the decision makers in the household. And so you have 5 cases of diarrhea instead of 10. Do you notice that, right? And so we see some of the main drivers in WASH come from one, fear of cholera. We see a lot of behavior change around outbreaks and epidemics. So we see, but also around, like, when we do behavior research, it's around, I'm a good family, I'm going to take care of my children, I want to provide my guests something nice, so a lot of these kind of aspirational, there's a lot of work within water around thinking about aspirational. If you have a nice, like the example in Haiti, a tap is people really like the tap on the safe storage container because it makes them look like they have flowing water, like in a household. So triggering these kind of aspirational things, but each of these things are going to be different in each culture, and the behaviors change so you've got to figure those out, like Eva's talking about, within each place. Sanitation is there's a lot of debate in sanitation because you can use there's a large disgust reaction to sanitation. And so people talk about, should you actually take feces and put like 1 gram of it and put it in water and shake it and then ask people if they want to drink it? And then they have to, like, do you trigger that disgust reaction? And there are people that promote this. Do you trigger that disgust reaction, or is that actually unethical? Right? And so there is, but one thing, this huge driver around sanitation is this disgust. We don't want to deal with our own feces, and for very good evolutionary reasons. And so how do you kind of work with that trigger to get the behavior change? People have to have water to live. People are going to find water or they're going to die, right? People don't have to have sanitation. So they're very different interventions. I don't know if that answered your...
Can I?
Yeah, so the way what I was sharing, how it works is that we are trying to work with about 300,000 slum population. So, and this is spread across 54 slums, 27 in Indore, which is in a city of 3 million in the center of India, and 27 in Agra, which is the city of the Taj Mahal. So there, the type of indicators that they use are qualitative community level indicators. So if, for example, we take the case of toilets, they would assess at the community level through discussion and if required transacts, what proportion of the households in this community have toilets. So if they think that most households, which would be usually close to 3/4 to more than that, they would assign it a green dot, and if it is very poor, so it's less than 1/4 usually, they would assign it a red dot. And if they think that this community is better than red but not yet green, they would assign it a yellow dot. Similarly for water supply, do all families have adequate water supply? This is not drinking water, this is general use water, because we haven't yet reached this stage where we have this treated drinking water. So they would again assign similar dots. Now this is as an outcome indicator, and this can be seen over time, like if every 6 months they assess whether red has moved to yellow or not. Now the effort indicator is whether the community is strong enough. So how do they see that? Whether the group is formed or not yet formed, whether it broke up, whether the group is able to conduct sessions or not able to conduct sessions. So again, they would assign within this community, the group or groups are strong. So that would be green. In this community, the group has broken down. So there is a red situation, which is like an alarm signal for us. And this community is still evolving, not yet green. And the related measurement which involves the authorities is the governance measure. Is the demand side of the governance taking place? Is the community exercising its power and entitlement to demand services from the government? Is it submitting enough petitions to the municipal corporation? So there again, they would assess that these communities would be assessed as green, these as red, and the rest yet to reach green or need more effort to reach green. So this is like more of a measurement which propels action at the moment the measurement is happening.
Thank you.
Peter.
Yeah, I want to add my thoughts to Dave, that this truly inspirational work that you're all doing, and we're all humbled by it, and it's great to see the mixture of social science with ecology and health sciences, and turning that into active work. But my question is, some of these populations, some of these slum populations are specifically there because they're disenfranchised, because they're a different ethnic group or a different political group or a different class or whatever, or illegal immigrants in some cases. How do you deal with trying to do this work when the government doesn't really want those folks there and maybe doesn't want you there, making their, as you're doing, making those slums more secure and more permanent? How do you deal with that? What's the way you communicate?
That's a very good question. So initially, we did face a lot of opposition from the government, and they even did not want me to use the word, which in my own, foolishness I used. I used the term illegal slums. So of course, I quickly learned that, the language to be used is different. And eventually, I realized through the good officers within the government that it is the listed versus the unlisted, which is also documented in government literature itself. So I stopped using the word illegal. So that was one step. The second thing which I made a mistake was to first present the findings from one city and say that this is the proportion which is unlisted. So that was another mistake, because then we collected evidence which I had shown from more than 12 cities, and it was evidence from the officers and functionaries of the government of those cities. So we were not signing any letters, which we made the mistake in the first city. We were not signing minutes of meetings. It were all the local officers, whoever was available. It could be the district magistrate, it could be the municipal commissioner. So that is how we slowly were able to help the government understand that the Constitution, in the case of India, does not hold human beings as illegal. And more so for the case of health. There were several heated arguments in meetings, one of them in which I gave my own example, that if Delhi is in a seismic zone, so there are tremors at times, but houses can fall as well. So I said, if I was in an unauthorized location, which could be a railway platform, so I don't have any entitlement to stay there, but I'm perhaps there for 3 months, what would I be considered? Would I be an illegal citizen? What would I be? And that is how they started thinking, and that is how it's come in the policy. So whenever anybody has time, you can go to the National Urban Health Mission, and you'll see that it explicitly says listed and unlisted slums and other vulnerable populations.
And I think a couple examples from places I've worked. I think one thing is governments don't want disease. They don't want to have to report cholera to the World Health. There's, no matter what the population, there is that. And in some cases, the population may be marginalized or is marginalized for whatever reason, but provides a benefit to the government. And I think in the US, certainly we have undocumented workers here, and they pick our fruit, right? And we're not going to pay fruit pickers the wages. And so there is a benefit, and those tensions move back and forth. And it's about lining within that to understand where the balance is. But I've worked in Dadaab refugee camps, 450,000 people, Somalia, in Kenya, in the desert. They absolutely don't want to take that aquifer water, which is not being recharged, and give that to 450,000 refugees. They get 6 liters of water a day. It's 110 Fahrenheit, right? So what they're doing is this balance is you can take the minimum amount for human survival and give it to the refugees, right? The refugees aren't providing anything to Kenya from that, but they're getting political will because they're a host country, right? So they get money from the UN, they get good political will. And so these tensions in refugee camps are really tough. But the balance there is almost what I consider not enough water to survive. It's like you just keep going. In the Batais, which are Haitian communities living within the Dominican cane and picking the cane, much like undocumented workers here in the U.S. We see if you provide too many services, the companies raise the rent. So you can provide services into the Batai communities, but it has a knock-on negative effect to the population, right? And so there's these. I don't know if that kind of. I would say overall, within WASH, we struggle to put in the hard infrastructure in these contexts. We can give household water treatment, or we can give, but we can't provide the level of service that we want to provide. But there's a balance that's struck. I don't know if that answers. Yeah.
Okay, yeah, 5 more people wanting to ask questions among the forum, and 5 minutes, or no, about 10 minutes. I know the coffee is waiting for us. Carrie.
I just have a really practical question. So say to Eva, so you said that you went into Mexico, to Acapulco, and started your program. Like, how do you take the first step?
Like I said, no, you work with people who've worked there forever. I mean, I've been working in Nicaragua for 30 years, so, and we worked with a group that already works, in community. CIET has been in Mexico and in the Universidad de Guerrero and in the Costa Grande and Chica, in those rural areas, they've been working for 20-some years, so you don't come in like, and it's all about building trust, et cetera.
Yeah.
So, but, you partner with local organizations that have a
Okay.
track record and are trusted and want to, are interested by taking a new approach.
Okay, so that's kind of pretty easy to figure out.
Well,
After
yeah, I mean,
you've
you
been
work in
around
a
the
community, but
block a
like,
while.
so we would go to, whatever, Sinche Barrio, and you come in and you say, but they hadn't been working on this project. They've been doing
Yeah.
surveys
Oh, I
on other
see.
things, so, but they're known in that community. So you knock on someone's door, hola, doña, ¿quién se preocupa por la salud de su barrio? Like, who is worried or interested in the health of your neighborhood? And they'd be like, oh, Doña Maria. And then you go, okay, Doña Maria, no, do you have any friends who'd like, oh, yeah, your tia, okay, perfect, like, let's go. And so you build it through their own community things, community networks, essentially.
Through trusted community networks.
Yeah.
David,
Thanks very much indeed. First of all, just a really brilliant morning. Secondly, I'm really wanting to pose a rhetorical question, and I would like it to hover in the middle for a bit. The question is as follows: what is stopping this kind of approach from happening everywhere? And I've got some hypotheses. Number one, we have to change and be ready to change the narrative. And Daniele really started with that when she made her presentation, but it was very much hidden in Siddharth's and Eva's presentations as well, in my view. Secondly, as well as altering the narrative, we do need to have quite a clear approach that is followed, and to try to distill out of these presentations and other experiences what that approach is. Because, as Eva said at the beginning of her talk, a methodology does matter. If you're trying to get this approach adopted elsewhere, it requires a methodology that can be taught and that can be learned. Now, on the narrative, I found two key things. Number one, we have to shift language from, for example, changing the behavior of ignorant, difficult, or reticent populations, which is how, certainly when I started out, often working in urban communities was portrayed, to enabling people to do stuff with our help. So we shift our role. And that means we move from instructing to engaging, from engaging to encouraging participation, from encouraging participation to stimulating ownership and local management. Now, I did think that as soon as you go down that path, you do get into trouble with local authorities. And Siddharth, I was just thinking, you must have had, as you just said in your answer to the last question, you must have had to do such a lot of negotiation. And so it's not just earning the trust of the community, it's earning the trust of the local authorities and trying to help the local authorities appreciate that you're not simply going to become a tool of the local politicians who get snarled up in this stuff before you can blink. And that then led me to think, should we perhaps include very explicitly within this the focus on trust building as well as on other stuff. So I just wanted to say that I think our collective job is to help build a typology and then a methodology out of this, and actually include within it the shift of narrative that is at the center of it. And I think it applies to communicable diseases, like the viruses we were talking about. It applies to water and sanitation, and then it applies to absolutely everything else. And it's back to the point I said at the beginning. I don't think that it's valuable to draw boundaries around this. It could be about health, education, resilience in the face of bad weather, nutrition, security, particularly of women, and more and more. So it's a bit of a comment, but it's because I just felt, let's just say these are individual examples, but let us be ready to work on an approach, a typology, a narrative shift, and then a new pedagogy.
And I would add to that a language that's being used a lot in emergency response now. It used to be you went into the emergency, you decided, I'm going to give everybody a filter, I'm leaving, right? The numbers are too large, the costs don't work anymore. And so now it's go into the emergency, study what's going on, and figure out the inflection point or the nudge. What can you do? Like in Syria, the water trucking's there. Make it clean water. The nudge is get the chlorine into country. It's hard to get chlorine into country because it's an explosive, it's a weapon. UNICEF can do that. So what's the nudge? And I agree, I hate the term compliance. I hate the those poor people didn't comply with me and treat their water. I hate that term. And I think this movement, you're exactly right. We need to move more toward understanding the community and what are the nudges. You're finding out the life cycle of the dengue and it's all, and that is coming partly because the populations are so large, you just can't simply spend $20 a person to give them what you want to give them. Yeah. So, yeah, it's a
Can we
great
still,
point.
I know there's a comment, but wait, so one thing is, yes, I mean, and I didn't have time to go into, but in both in Mexico and Nicaragua, they very carefully mapped out what's called the Ruta Cepa, which was exactly, essentially, these are the critical points, and then under each one, this is how you get there. But in essentially as illustrating, what are how you would approach this, and then how, what the pieces are, but you do that separate, differently in each country. And so we also, there's one main paper on that, but now we have 26 other papers that have come out in a special volume of BMC Public Health that go into a lot of the detail of exactly how this happened and how it worked. So that was kind of the backup. I think the changing the narrative, it's interesting in the vector control area, and I mean, Tom really can speak a lot to this as well, but so it's interesting because there is kind of openness to, knowing that it's not working and that we need other strategies. And of course, there are other types of insecticides that are being developed also, but then there's also openness, I think now, to really having community be part of the story. But it's also difficult in the sense that governments are very vested in kind of the standard approaches. So they're used to, if you're in the middle of a really big dengue epidemic, you have to go out and fumigate because the population is expecting the government to do something. And so, and so even if it's not going to be effective, sometimes it is effective, but it also, even if it's not effective, you're showing that you're doing something. And so, and it's very interesting in Nicaragua because the whole concept of health is based on salud y familia y comunidad, and it's like this whole, not only rhetoric, I mean, they really have, everything's based in community, and so they're very receptive to this, and this whole project is really being done, this next phase with the ministry, and at the same time, they're still running around with abate and fumigation, so it's like totally this contradiction. And I have to say, there's a ginormous vested interest of industry. There's a lot of money in this. And that's a really difficult problem. So there's kind of a big meta-political and economic issue going on as well. I'd be interested at some point to hear Tom's thoughts on that. But we definitely feel that there's kind of, it's all acceptable till a certain point. And if you're going to reduce your compras of the chemicals, then you're in trouble. So I feel like there's kind of some big issues going on as well.
Let me just
Can I just
have Edward, someone? Steve wants to, okay. Steve, can you hear us?
Yeah, I just wanted to say from my perspective, we're talking about these interventions. I see this as development. We're talking about the poorest of the poor. People don't like to live in poverty. And the projects I've been involved with over the years, you put in sanitation, people are delighted with that. You put in new types of house screening, people are really happy. We've just come back from the Gambia where we're doing a project on a new type of screening of the door. And everyone's cleaning the doors every day, apart from the young men, of course. But, this is development. This is helping people develop and live in conditions that you and I take for granted. And with development comes improved health.
Thank you.
Yeah.
Edward, you.
Good morning. Thank you for the wonderful presentation. It gave me a lot of food for thought, and it's forming a model that I'll try to describe later this afternoon in the wrap-up. But two very quick questions for clarification. Dr. Agarwal, you mentioned that with regard to health investments, there's some aspects of risk aversion. I was wondering, can you describe what some of those risks are, either perceived or real? And for Dr. Harris, for the survey, I was wondering also, is there an opportunity to talk about what the potential financial impact are, like improvements? So if there's decrease in disease, then there's less of an impact on family members having taken care of other sick members, and is there an increase in productivity, and would a survey be able to capture that? So just two very quick questions for clarification.
Thank you. The risk I was mentioning is more about any funding wanting to see results which are predetermined at the time of the proposal. And they do not want to take the risk of learning during the course of implementation. So that is the type of risk which I was mentioning. It's for implementation as well as for action research in both cases. But I also quickly take the opportunity to respond to David's point that we must be running into this trouble quite regularly. We've learned over this course of many years that one should work very collaboratively, also train or help the community learn to be collaborative with politicians, with authorities, and use the appropriate language in those letters, which I was using the word petitions. Make them very specific, very polite, no confrontation ever. And always offer tea, water, cookies to the functionaries when they visit your slums. So these are small aspects. They might not be easy to research, or they might require a lot of money to research. Our organization does not have that resource. So we're not able to research this on a large scale, but we learn from experience that wherever that collaborative effort works. So for example, ward member, ward cooperator, and who directly works with the mayor. So that is the real link, and that person is usually close to that neighborhood. So that person also needs the votes. Occasionally that person may need a little nudge by showing the voter ID, which was the reason why I mentioned the voter ID being crucial.
Yeah, absolutely. And so that is some of the data we captured, is essentially like how many days have you been out because of your sick child or yourself, et cetera. And so that's all quantifiable and quantified, as well as, the whole moving into the new, because when we did the CRCT, we were in 60 new barrios, and the entry point was actually a essentially a cost study and focus groups based on how much are you already spending on mosquito control. And that really motivated people, because when they added it up, that was like a reason to, and it wasn't working, right? So then when they realized that, they were like, yes, we want alternatives.
Okay, we are just about over time. Should we open it up to one or two questions outside the forum? Any members outside the... Many questions. Okay.
I have a quick, so my name is Umair Shah. I'm the Executive Director of Harris County Public Health, the County Health Department in Houston, Texas. So third largest county in the U.S. I'm also the president of NACHA, the National Association of County City Health Officials. And I just want to say fantastic panel this morning. We're one of the only, if not the only health department in Texas that has a One Health, environmental health, human health, animal health, and entomology all together. And what I find really fascinating in the midst of our Zika response the last year or so was that we really very much understood the real importance of engagement, but not just engagement and health education, but really behavior change, which I think is exactly what you all are referring to today, is how do you get oftentimes folks that we marginalize ourselves and we identify in a certain setting and say, here's the label, and how do we engage and really show resilience and show positivity and share cookies and those kinds of things to really, at the end of the day, find this bidirectional way towards really common understanding of health and how do we proceed towards that. So I just wanted, my question back is really on that, the importance of that global health perspective that helps domestic health here in the U.S. There are themes that are going back and forth that I very much think resonate with local health departments across the country here. And if you just want to share with us maybe just that, the themes in your minds of how do we translate global settings with what happens potentially in a domestic setting here, which I think is absolutely important and critical. Thank you.
So, and I just want to mention one thing, that I didn't mention Zika at all, but like the whole focus in the last 2 years has been using that dengue chat, et cetera, it's called Zika chat, actually, and it was all, aside from the mosquito control, there was a whole section that Josefina led about Zika, essentially with pregnant women, and they have like, all kinds of tools and stories of, how to deal with the whole Zika and pregnancy story. So that was actually integrated into the whole piece of community education. So, I've tried to talk also with the local boards for abatement, et cetera, in our area, in the Bay Area, because it's different. There's a couple of really big differences in terms of community engagement and et cetera, but there's also equally breeding sites everywhere and like bird baths. And it can be different. We might have barrels for, because we have intermittent water, but there's a lot of places where mosquitoes breed around, species and other. So there's definitely ways, and I've been trying to see what are the elements that can be used in just getting communities or people, residents able or willing to be more involved. And I think that there's been definitely receptivity on the local domestic side for incorporating some aspects that might make sense in this kind of different environment. So we are kind of trying to move that in that direction.
I think on the WASH side of things, and from Houston, a lot of the work I do on decentralized WASH in emergencies in developing countries, I bring back to the U.S. when we have an emergency. Certainly there's household water filters being used in Flint, because the drawback of infrastructure is if someone does it wrong, you impact a lot of people. I got a lot of calls, particularly what's going on in Puerto Rico, a lot of use of aquatabs and other type of interventions we haven't seen being distributed in the US, but because of how the Puerto Rico response is happening. And then the normal hurricanes like Houston and Florida, for the week or 2 or 3 that you need the interventions short term. So I think, and then there's a larger sense, and this comes from a whole different side of people, but how long can we maintain the US water and sewer infrastructure and meet the regulations for new chemicals each year and provide this 150 gallons per person per day of drinking water quality water to every individual in the US through infrastructure? And there's a question of, do we see a sea change? And one of the things I teach at Tufts to the engineers is, when's our new sanitary revolution? And does it involve like aspects of, we don't need to be watering our lawn with drinking water quality water, right? Like, how do we figure this out and make this whole, we don't need to be putting all the nutrients and feces and urine into clean water and then treating it and not using them. How do we change this? And do we have a second infrastructure, sanitary revolution here in the States? And so I think I anticipate as time comes on that a lot of what I'm doing now is going to come back more and more to the U.S. as we have more emergencies with the climate change and as we have more, as we think about infrastructure. Yeah, thank you.
Albert, go.
So thank you for the whole panel. Those are very insightful presentations. My question's for Dr. Lantagne. The 2 questions. One is latrines really a viable long-term solution for urban slum populations, especially in these mega cities? The second one is really the role of subsidies. If in the implementation pathway and how we're trying to increase coverage, if poverty is the barrier, or if high negative health externalities, are present, it's kind of hard to think of approaches that don't include subsidies or conditional cash transfers. So if you could comment on that.
So the first is, I absolutely don't think latrines make sense in urban slums. Partially just space, land tenure. Also, they fill up, where do you put it? There is one program where there's desludging in an urban slum. They literally have what they call a gulper. They go into the latrine and they gulp out the sludge and they take it away. but that's in Tanzania. But I think latrines aren't going to be the answer in urban slums, and I also think they're not. There's real questions of if they make sense in rural areas, partially because children are scared to use them. Child feces ends up on the ground. Do people use them? What happens when they fill up? The people handling the waste, yes, it isolates feces from the environment, but the people handling the waste actually have increased risk of disease and transmission. And so I do want to change the narrative and move away from latrines in general. And I think some of these options, providing people toilets and collecting or centralized places to defecate, I think are much better options in urban and in dense contexts. And I have no problems with subsidies. I actually think we talk about dividing up socioeconomic status. You talk about the quintiles, what quintiles can afford it, what quintiles need subsidies, conditional cash transfers and unconditional cash transfers. Both, all of the data coming back, emergency is moving this direction. Emergency response, because if you give cash, it stimulates the local economy. The research that's coming out from the randomized control trials, I think we're going to move more to these conditional and unconditional cash transfers. And I don't have an ethical problem with that. I think they work, and I think they stimulate the local economy, but it doesn't, I mean, it always feels better to give something and a picture, and there's a picture of you and the community and the well. And it's the same thing here. When there's emergency response, we want to give something. I mean, in my community, I almost went crazy. On Somerville Moms, they were collecting our baby carriers so that a woman could fly to Syria or Greece or whatever and give, like the baby carriers you put your baby in, and she gave the carrier to people there as they were walking as migrants so they could carry their babies. And I'm like, it's great to give them that, but they don't have enough food, and you can buy baby carriers there. And I'm like, but we have such a desire to have that physical connection with a thing and a picture, but I think cash is more efficient. And that's, so, yeah, I don't know if that answered your question.
Okay, do we have time for, we're over time. Okay, Emily, one more question?
So I'm really captured by this idea of communities collecting their own data and monitoring their own exposures and health status. And I think that can motivate them to come up with their own ideas and help them through that. We could probably come up with something for water. And they already have, I can see it in a glass, it looks dirty, I know that this is bad water to drink. Maybe technology could help us. And I know that in some places they're already doing this with things like air pollution, right? So that communities can monitor their own air pollution and feel involved in that process. And so just to throw that out there, that I think that has legs in terms of interventions and getting people with the context knowledge appropriate to answer, to make solutions, giving them the data to empowering them to do that.
There's a huge move toward that. The limitation right now is most of the ways to test if water is safe require either culture or PCR and time, but there's a ton of money from UNICEF, the UN, and donors going into rapid water testing because people want this water. Because yes, if it's dirty and you see it's dirty, but a lot of people say it's clean if it's clear, but it's not at all. And so how do you, can you get something on the iPhone or a dipstick? And there's money going into all kinds of different places on that. We don't have it yet, and I think it will change the game. Yeah.
Okay, great. Lot of food for thought, a lot of interesting ideas. We're going to continue this discussion afterwards, but as Siddharth mentioned, the key to a successful meeting is good food, coffee, and tea. So that's waiting for us now. So let's thank our panelists on this wonderful session.